Okay, everybody, we're going to start now. So if you could take your seats, please. As you can see, we have a channel of communication through to Gaza, and I'll introduce our two guests in a moment. My name is Richard Horton from the Lancet, and it's a great pleasure for me to be introducing this evening. We're going to hear some great speakers, and it's also a great pleasure to be running this event in collaboration with UNRWA, Medical Aid for Palestinians, the International Federation of Medical Students Associations, and of course the Lancet. And most importantly, our friends in Gaza. Let me get out of the way because I'm blocking them, and it's just that they can't see. Anyway, fine. You know, when we planned this session, we have this now every year at the World Hellth Assembly. When we planned this was well before the recent events that have taken place in Gaza. And so we are meeting now at another time of acute crisis. It's an acute crisis for Palestinian people, particularly the people in Palestine living in Gaza. It's an acute crisis for UNRWA, and you're going to hear more about that later. And it's also a crisis for any notion of a political solution or solutions to the ongoing health of the Palestinian people, including Palestinian refugees. Writing in the Lancet just a few weeks ago, after the first 17 deaths of Palestinians protesting against their land confiscation, Kamis Alessi, Kamis, wave, hello, there he is.
Hello.
So great to have you actually with us. Kamis, who is at the Faculty of Medicine at the Islamic University in Gaza City, wrote under the title of From a Short Day of Commemoration to a Long Day of Mourning, about what he described had taken place as the bloodiest days in Gaza since the 2014 Israeli-Gaza conflict. And I just want to, for those of you who haven't had a chance to read his letter, I just want to read the final paragraph. The deaths and injuries arising from the Israeli army action against civilian demonstrators are beyond what might be expected from mere efforts at crowd control. They raise serious concerns regarding the risks of escalation as the demonstrations continue. Already, the health and trauma facilities of Gaza have been overwhelmed in taking care of those severely injured. The people of Gaza are under heavy economic and social pressure from the blockade and the ongoing siege, dating from 2006. These demonstrations, conceived as non-violent, were designed to show the world that Gazans still have the spirit to resist what they see as their oppression, and that they continue to call for lifting the siege on the Gaza Strip and the resolution of the Palestinian question. Now, we published that letter from Kamis on April the 27th. And a great deal has happened, as you all know, since April the 27th. Now, what we would like to do this evening is to update you directly from Gaza about the current situation there. And we'd also like to set that in the broader context of the Palestinian predicament for the peoples of Palestine living in the West Bank, East Jerusalem, and Palestinian refugees. We would like to examine the unprecedented financial crisis that's facing UNRWA and what that's going to mean for the Palestinian people. And we'd like to look at where we go from here. What can we do together, given this current predicament? Now, as I say, we have a fabulous group who are going to present to you, and I'm going to introduce everybody in one go, and then they can come up and give their presentations, and then we've got 2 hours together. So we're going to then have the opportunity to discuss what we think and what we should do. Our 2 honoured guests here, I've already introduced one, Dr. Karmas Alessi, but also we have next to him Dr. Marwan Abu Saida, who is the head of surgery at Al Shifa Hospital. Dr. Marwan, welcome. You're very welcome. Thank you for joining us. And then we are going to, the running order is going to be Dr. Gerald Rockenschraub, who, as you know, is the head of the WHO Office for the Occupied Palestinian Territory. He's going to be followed by Dr. Hend Harb, who is the head of the Health Center, the UNRWA Health Center, and the health program in Gaza. Then Neil Salmons, it's his first World Hellth Assembly, he's telling me today, and we welcome you, Neil, very much. Neil is the Advocacy and Campaigns Director for Medical Aid for Palestinians. After Neil, we're going to have Dr. Sater, who we have to thank for organising this with his team, who's just been fantastic, as you know. You're a hero. You're a hero. As you know, Dr. Sater is the health director of UNRWA and WHO special representative. Then Alistair Agger is going to speak. He is director of the International Global Health and Development Center and a professor of population and family health. That's what he does for part of his life. The other part of his life is he works for the Department for International Development in the UK. And Batul, do we have Batul? Yes, Batul, we haven't actually met this time, but Batul, it's great to have you here. Batul Al-Wadani, who is the Vice President for External Affairs for IFMSA. So I want to start by giving the floor to Dr. Alessi and to Dr. Marwan. And I hope we've got the volume all turned up. And over to you. Who's going to start? Carmen, start Marwan. How would you like to go?
Yeah, Dr. Marwan will start.
Okay. Thank you all.
Thank you for the opportunity for you.
Okay, this is the burden already health sector in Gaza. What has happened? I will tell you now my story. What I'm doing in Shifa Hospital, how we cope with the situation during the marches of return, during the start of marches of return. Our Minister of Health and all the health workers here in Gaza were prepared were prepared to take care of the people who will have gas inhalation. But unfortunately, all of the Ministry of Health and all the other NGO sectors who are working with the health sector in Gaza, they were prepared just to take care of the people who will get in, who will have gas inhalation during the peaceful protest at the side of the borders. But unfortunately, we at our hospitals received many casualties, really with the gunshot injury, with the severe injuries. Our Ministry of Health prepared themselves and prepared the situation by establishing emergency medical tents, or what we call it, emergency medical points, at the site of a protester, at the scene there. And these tents, its aim was firstly to deal with the gas inhalation cases and to deal with minor cases and to stabilize severely injured patients, then to refer them to our hospitals. In the first Friday, which is 30th of March, we have received huge number of gunshot injuries and a huge number of gas inhaler, but not at our hospitals. At our hospital, we received the gunshots injuries. I was in Shifa Hospital in 2014 during the war on Gaza, And in that war, we treated, injured more than 11,000 people who got injured in that war. But in 7 days, in 6 Fridays and 1 Monday, we have received more than 13,000 casualties. Among them, about 40% were gas inhalation, and the 60% were gunshot injuries and other injuries. And the gunshot injuries were exactly about 30% of these cases. And in the last Monday, we faced with the mass casualties. In the past Friday, the 6 Fridays, we faced with multiple casualties that were not overwhelmed our local resources. But on Monday, it was really a disaster because of the casualties. It was massive casualty, mass casualties. A lot of cases came to our emergency department that we couldn't deal at the scene really. Okay, we dealt at the end, but really it was beyond our capability, beyond our capacity. At Shifa Hospital, which is considered the largest hospital in Palestine and in Gaza, we established a tent, which is called a triage tent, in front of the emergency department, which is just in direct contact with our emergency departments, just to triage the cases. At the start of in the morning of 14th of May, on Monday, we just did the triage. The green cases we dealt in the tent, and yellow cases with the people who got injury with the bone injury and the vascular injury, we let them to enter our emergency department. But after an hours, our hospital were overwhelmed with the cases. Our emergency department were overwhelmed with the cases. In that day, we have received more than 500 cases at Shifa Hospital, and more than 231 patients were admitted to the hospital. In that day, we've done more than 79 cases just on Monday, and in the following days, on Tuesday, we did more than 64, and then the next day, and the third day, we did more than 35 cases. All surgeries were performed for the patients who were admitted on 14th of May. We did most of our patients who arrived to our emergency department, 60% of them, they've got injury to the lower limb with severe destruction of the muscle, of the bone, and injury of the vessel. We were in a lack, we were in a deficiency of vascular surgeon. We have enough number of vascular surgeons that can deal a regular situation, but in situation like mass casualties, we were triaging our cases again, not in the emergency department, to red cases to go immediately to the theater. No, it is again in the recovery area in the theater. We had to do again another triage for stable patient to wait, and for unstable patient can go to the room. But unfortunately, at that day, we had more than 15 operating theater. All were occupied by injured people. And we were in a lack and deficiency of vascular surgeon to deal with the large number of cases that got injury to the lower limb, especially to the legs. And this is a unique experience and the unique situation in the whole of the world, that most of our cases that got injuries to the knee, they got vascular injury and compounded comminuted fractures of the bone in the leg. I think this is a devastating issue to our patients. Till now, our hospital is overwhelmed with the cases. More than 100 patients still in our hospital, still receiving treatment and management. Unfortunately, our patients who get injured to the thigh, or get injured to the leg, it is not injury, just we are causing more injury because he will get some swelling in his leg. So we had to do in all cases fasciotomy. At the end, our patients will get with the large wounds and gaps in the bones and loss of circulation to the lower limbs. Still, we are discussing the issues of these cases. The sequences of these cases is still long. Most of these patients, I think, at our hospital needs still further management. For example, each patient who got injury to the lower limb, firstly, at the day of injury, we do surgery, we do repair, we do fasciotomy, but in 2 days, we do another dressing under the general anesthesia. And again, in the 5th day, we do some, because there is a gap of tissue, there is a gap of skin, we have our reconstructive surgeon, plastic surgeon, they have to do their flaps and to cover the lost, the raw areas. And still, most of these patients who got injury to the lower limb, especially to the lower limbs with the tibial fracture, with the leg bone fracture, they need a lot of surgery in the future. I think we've got work for the next 2 or 3 years. And most of these patients, maybe about 30% or 35% of patients who got leg injuries and bone fracture, mostly they will get some sort of osteomyelitis. And most of these cases, I think they need limb reconstructive surgery in the future. And this is very costly. And this is beyond the capability of our hospitals, beyond the capability of the work of Ministry of Health here. And I think we have to work for the solution of these people, not at the moment of injury, but at later on. Until now, we've done primary and secondary amputation for about 40 of cases in Gaza hospitals. And the number is increasing because of the loss of tissue, because of the poor vascular supply to the lower limb. And I think still the number of patients that in a hospital is very huge and demanding a lot of work and a lot of facilities. We started we started to deal with these cases with a lot of deficiency in instruments, in drugs, and sutures material. At the start of our work, we did not have sutures, Prolene 60 to deal with the vascular injuries. And we did not have enough tissue external fixator to fix the bones. Also, we did not have scrub materials to scrub the wounds. And also, we did not have the proper antibiotics and the antithrombotic agents. We have a deficiency in this material till now in our hospital, but we have to manage the cases. Always, I have a story. I have to fight at the morning with our pharmacists at our hospital because they have to change this antibiotic because it is not enough. We don't have the allocated fund. We don't have enough doses to treat all the patients with the same drug or other drugs. And another issue which arises in our hospital, multi-drug resistant bacteria, because there is a nosocomial infection and cross-infection between the wounds and so on. This is a huge burden to our institution. This is a huge burden to our Ministry of Health in Gaza. Thank you.
To say a few words too, please.
Yeah, one second.
Yep.
Hamis, your turn.
Okay. Thank you very much, beloved Richard, beloved Sita, Gerald, and Sam, and all the rest. We bow for your support and for your persistence to help Palestinians in every ordeal. And it seems that our ordeals is never ending. It seems every 2 years we're having a new ordeal with the Israelis. And we're always the victims, and they're always the oppressors. Just to update you with the latest numbers. So far, since March the 30th, which I call the Day of Return, from a short day of commemoration will be shifted by Israelis to a long day of mourning. And that's actually what's happening. Since that day, the number of injuries start rising steadily. And now we're having more than 13,000 injuries, divided between severe injuries, moderate, mild, and many of the cases remains in hospital belong to the very severe injuries. Till this moment, we have more than 54 cases who are brain dead, just residing in ICUs, on ventilators, and waiting 1 or 2 are dying every day. Okay, many of the patients, almost 40% of this total number of injuries, are due to tear gas. But the tear gas used by Israeli soldiers, it seems it is not like other tear gas because it's causing a lot of non-epileptic seizures among most of the patients, causing a lot of agitations and delusions among the patients, and many of them need to be admitted to hospitals, and some of them even died later on. Around 35 of the cases are due to rubber bullets. Again, the rubber bullets used by Israelis are metal coated by rubber. So inside the bullet, there is a metal part, and outside there is a rubber part, which also can cause severe injuries. The vast majority of injuries affected the lower limbs, and this has led to lots of amputations. And as Dr. Marwan mentioned, more than 40 cases has been amputated, and 5 cases in the upper limbs has been amputated. And when we think about amputation, we think about prosthesis. So those patients might need some artificial limbs in the future like this, which also add more burden on the Palestinian health sector and more burden on the Palestinians themselves, because this man who was injured, maybe he was the only breadwinner of his family. So the rest of his family and the dependent members of his family should find new work, despite the scarcity of any jobs here in the Gaza Strip, will look for anything to sustain their tummies here, because the only breadwinner is now disabled. He's now paralyzed. We know that based on UN resolutions 194, the Palestinians have the right to return to their homes. And what the demonstrators were doing since March the 30th till this moment, and will continue, are major Palestinian demonstrators just rallying in peaceful demonstrations. All international, all media outlets have testified that none even one single person was armed in these demonstrations. And all those kids and youngsters and women and men and elderly who were rallying in that area were just demonstrating peacefully against the Israelis and posing no threat on them whatsoever. So they have no right to kill them. In the long consequences of this war, I think it will have a long consequences on Ministry of Health first, with the already devastated and overwhelmed Ministry of Health in the Gaza Strip due to the 12-year blockade and strict siege on Gaza Strip, due to lack of salaries. No more salaries here. Most of the employees are receiving maximum 50% of their salaries. No jobs. Unemployment rate is above 45, some estimated to be 60. Poverty line is above 60% here among Palestinians. So in already devastated situation, overwhelmed Ministry of Health, hospitals having some of the essential drug list up to 0 level, many of other drugs are deficient, almost 50% of them. So these additional number of injuries, additional number of complicated fractures will add burden on the healthcare sector here, will add burden on the UNRWA healthcare sector here, will add burden on the WHO burden here. So instead of we plan to develop the healthcare structure, we are just providing emergency supplement to sustain what's going to die or fail sometime soon. Another thing is in the economy. The economy is already failing due to blockade of all borders. So when we have additional 13,000 Palestinians who sometimes are the only breadwinners of their family, meaning if we multiply this by 5, which is the average family members, we have more than 50,000 or 60,000 members are already unemployed later on, and they need sustenance. And not forgetting the long-term disabilities caused by these fractures and the need for care and rehabilitation, long-term rehabilitation for patients. So the only solution for this, and the only solution beside treating the injuries, doing plastic surgeries for the deformities, whatsoever, Okay, the only solution is to end the siege on Gaza, stop the killing of Palestinians, open the borders, allow Palestinians to live in equal matters like other people elsewhere in the world, and allow Palestinians to have their basic rights of living in dignity and sovereignty. Thank you very much.
Thank you very much, Kamis, Dr. Marwan. Please stay with us because we will have an opportunity for discussion a little later. Perhaps I could ask Joe to go next. That would be fantastic. Thank you.
Yeah, thanks very much. Let me maybe start, colleagues and friends, Richard, with complimenting those two guys in Gaza, because I think they are the real heroes here. I mean, before I became a bureaucrat in WHO some 15 years ago, I also was a surgeon, and I can very well remember when we in our hospital got 3 or 4 severely injured patients, we had to close the hospital, and we were fully preoccupied with that. I mean, they received hundreds of severely injured within a matter of hours, and they were still able to manage somehow, despite the desperate situation that they were confronted with. Now, this mass demonstration, largely peaceful mass demonstrations, started 30th of March. So far, we have seen 170 people died. We have seen over 13,000 injured, as they mentioned already, which means this is already close to the figure that we saw during the 2014 Gaza war. Within a matter of a few weeks, of a few Fridays, where these mass demonstrations were happening, and then on the 14th of May as well. 3,600 of those were actually injuries through live bullets, really severe injuries. Those live bullets are high-velocity bullets, which trigger quite substantial soft tissue damage and bone damage, which means that those patients, they won't be managed with one surgical intervention. They will need repetitive surgical intervention. They will need reconstructive surgeries. Some of them will need plastic surgery. Some of them will need vascular reconstructive surgeries. And some of them might end up with amputations. Some of them did already have amputations. Now, having said that, all this situation is not affecting a normally functioning health system. This is affecting a health system that was already on the verge of collapse when this actually started. And we are talking through the chronic blockade and closure of the Gaza Strip. We are talking about a health system that is chronically on the verge of collapse, that is facing de-development. We are talking about 4 hours electricity on an average per day, which means that most of those hospitals need to rely on emergency generators to at least manage to sustain the life-saving interventions and the life-saving services there, the surgical services, the intensive care units, and so forth. We have some 40–50% of the essential drugs being at zero stock most of the time, and now it's even worse, obviously, due to the increased needs, due to this overload of patients in the context of the current situation. And as already mentioned also by colleagues there, they are not even paid salaries on a regular basis. 50% of the doctors and nurses there, they receive partial salaries every 40 days. I mean, I spoke to a nurse when I was in Gaza recently. She walks every day 10 kilometers to the hospital to work because she cannot afford a few shekels to take a taxi to go there. And she still is committed to work despite not receiving a salary on a regular basis. This is the situation there. But I mean, at the moment, obviously, trauma cases are the big priority. But let's also not forget that there is still babies born there. There are still dialysis patients who need chronic disease patients who need their services. So this, you know, through the triage, I mean, the caseload has been shifted. There are 3,000 elective surgical patients, more than 3,000 in the meantime, whose surgical interventions had to be postponed because the system is totally overloaded with this increased patient influx. Now, what have we tried to do to be prepared for that? And colleagues mentioned that already. We have worked with the Ministry of Health, with partners, NGOs, to establish these trauma stabilization points, which are tents that provide basically initial life-saving interventions on the spot to minimize the caseload for the hospitals, to at least absorb part of the patient load in these trauma stabilization points. Then all partners have tried to front-load whatever supplies they had in the pipeline. I mean, UNICEF, WHO, MAP UK, you name it, all the NGOs that were involved have tried to at least release all the supplies that we had ready to deliver. And we have also called, in WHO, we have a mechanism to call for emergency medical teams. So we have activated that. MAP UK already has surgeons on the ground to work hand in hand with the colleagues in Gaza, mainly vascular surgeons, reconstructive surgeons that can help to at least cover some of the caseload of those additional patients. Now, obviously, the needs are huge. Maybe what I also would like to refer to is the increasing concern about attacks on healthcare. As of 22nd of May, we have recorded 238 health staff being affected either by tear gas exposure. 16 have been actually affected by live bullet injuries, and one health worker actually died due to a gunshot wound while trying to deliver first aid to some of the injuries. And 38 ambulances have been damaged. This is in contradiction to the respective Security Council resolution. It's violating international human rights and humanitarian laws, and we are very concerned about these violations on healthcare, and would like to emphasize that health workers, health facilities need to be protected at all times. Maybe to conclude, I just would like to raise an issue which you may or may not be familiar with. For Gaza patients to get services, specialist services that are not available in the Gaza Strip, many of the specialized services are not available, be it chemotherapy, radiotherapy for cancer patients. They need to get the security approval by Israelis to get those referral services outside the Gaza Strip, either in the West Bank or in the East Jerusalem hospitals or in Jordan or elsewhere. We as WHO are monitoring the approval rates of those permits, and in 2017, 54% of those patients received a permit in time to get in time to their referral services, which means that more or less half of the patients don't get a security permit to get referral services in time, which is a huge restriction of the right to health for Palestinians, particularly for Palestinians in Gaza. So the situation is dire. What can we do? I mean, we as WHO try obviously to mobilize resources to address the most urgent gaps. It's very difficult, by the way, to bring supplies into Gaza. We need to have approvals by the Israelis, who usually, I mean, grant us the approval, but it's a very time-consuming process. We need to get customs clearance, we need to get approval by the Israeli military, and sometimes we need to get extra approval by the Israeli Ministry of Health to import equipment and so forth. Last but not least, what we need is your collective advocacy, as the colleagues mentioned, because the only solution can really be to lift the closure of the Gaza Strip and to grant the Gazans the same right to health that everybody else enjoys. Thanks very much.
Thanks very much, Joe. Dr. Hart.
Good evening, everybody. I'm Dr. Hind Harb from UNRWA. I'm head of health center in Gaza Strip. As you know, UNRWA is serving Palestine refugees in 5 fields. Gaza is one of them. we have 22 clinics inside the Gaza Strip. 11 of them are inside Gaza, inside camps, and 11 of them, the other 11 are outside the camps. As you know, we are providing services, healthcare services for more than 70% of Palestinian refugees who reside inside the Gaza Strip. When I came here to Switzerland, I faced many challenges. I'm one of the 1,000 healthcare providers in Gaza Strip. I am the luckiest one that I had the permission to cross areas control and valid UNRWA. So I'm pleased to be among with you. We are providing health services in this astonished situation in Gaza Strip, especially after the 30th of March and the increasing of casualties, as Dr. Khamis said. Especially these days in our health centers, we are providing health services for injured people. We started to receive injured cases after gunshots, especially in the lower limbs. So there is an increase of the demands for dressing materials and dressing staff in our health centers. Also, with the increase of these casualties and the amputation of the lower limbs after surgeries, the increase for physiotherapy in our health centers, as we have 11 physiotherapy units in our health centers. So the increase of this service will be seen soon or later after these cases will be recovered after amputation, and they will need also orthopedic devices, as UNRWA also helps Palestinian refugees to have these orthopedic devices. Also to illustrate the whole picture of our services in Gaza Strip as UNRWA, we also provide health services for all categories from 0 age till adolescents, and for NCD patients with the siege, which remains for more than and blockade for more than 11 years. We are facing a shortage of essential medicines and sometimes of vaccines due to the restriction from the Israeli side to deliver these essential drugs and vaccines to UNRWA and the Ministry of Health. Also, after the cut of salaries of some of the employees, the increase of demands to our services, because we are free of charge. Some of refugees, they didn't access our services before, but now, because the cut of salaries, they are accessing our services. So the number of people who are accessing our services is increasing, so the demands is increasing on UNRWA, especially after the deficit in budgeting the UNRWA this year. Despite of that, we are still providing our health services with the same quality that we used to give to our Palestinian refugees, as I am one of Palestinian refugees. Also, our services is provided with best quality as we are implementing family health team approach in our 22 health centers, and electronic health, and the integration of mental health gap in all of our clinics. We celebrated recently this month the full implementation of the mental health gap in all our 22 clinics. I have to mention also that our refugees in Gaza Strip, as Dr. Gerard said, they are restricted from traveling to have tertiary healthcare or healthcare that is not provided inside Gaza Strip. So not all the patients have the permissions. Even some of the patients have permission to go outside Gaza. Some of them, they are children. They were permitted to go alone without their mothers and their fathers. If you can imagine a child who is, I think, 10 years old, she went to West Bank to have kidney transplantation without her mother. This is devastating, and it is unhuman also. I want to tell you about one of our success stories as we are integrating mental health gap in UNRWA clinics. And I want to mention also before that there is an increase of suicidal attempts among adolescents and young males and females. Once a day we had a child, he is 15 years old in the 9th class. He presented to one of our doctors saying that I don't want to have to be alive. I want to go outside Gaza. I don't like to stay here. Maybe I want to get some medicine to kill myself. She was astonished, this doctor, and she called for help from her colleagues. Also, we are implementing family health team approach. We called the family, we called his mother and his father. We managed the case properly. Sessions were given to this child with his mother and father and the whole family. And at the end, we succeeded to move this child from a child with no hope to a child with a big hope. We discovered that he has painting and drawing skills. And in our health center, I am a manager of Rimal Health Center, which is located in the center of Gaza. We celebrated the World Health Day, and I announced for a painting competition. He attended the celebration, and he painted for us lots of paints, and he won the competition. And I asked him before coming here to paint some paints to give to the panel. And these, I have 10 paints from him. He is the Dia, and I am proud to give you some of them. I would like to thank you all, and I would like to thank Dr. Sita, who gave me this opportunity to come here and to tell you a little bit about our situation in Gaza, and especially in UNRWA. We hope everything will be okay, and with the support of the world and the whole community, we hope peace will be soon. Thanks.
Thank you very much, Dr. Hart. Now, let me introduce Neil.
Very difficult to follow that. I think such respect to Dr. Hind and Marwan and Dr. Khamis in Gaza. It's heartbreaking what you're saying, but extremely impressive and motivating as well. And Ramadan Kareem to you. It's a little bit incongruous being in clearly like the Intercontinental in Geneva with the link up to Al Shifa in Gaza. And I would like to take you to another place briefly, which is Lebanon. So, you know, as Richard was saying, as we were leading up to this event, we weren't expecting that this was going to happen with the Land Day and beyond protests in Gaza. And as you've hopefully seen, we have on the table here, and you've probably just picked them up, MAP's latest report on health in exile. This follows the report we did at the end of last year, Health and Occupation, looking at Gaza and the West Bank. Various particularly political barriers to Palestinians accessing healthcare, like referring to. And now we're looking more at the Palestinians outside historic Palestine. So if you can, think of this scene a second, and while you're there, try to consider and count up what injustices and hardships are around this context. So there we go. We go off a side alley and we go to a map-supported NGO. This is in Badawi refugee camp in North Lebanon, above Nakba, North Tripoli. And there's a Lebanese psychologist working with Palestinian children. Beside them is a toy doctor's play kit. What do we have there? So, first of all, we've got the children who are meeting with the psychologist. They've got their mental health.
Can you speak up? Yes.
Yes. Sure. Is that a little bit better?
Yeah.
Can you hear me okay? I think it's unidirectional. Is it direction? Like that? Yeah.
No, I think they have to hear you through.
Yeah? I think they can hear. Maybe I should do both, just in case. Anyway, so the children have their mental health, psychosocial needs. It's estimated around 90% of Palestinian refugee children in Lebanon have been exposed to traumatic events, and they live miserable lives. There's next to no access to mental health, psychosocial services for Palestinians. It's pretty poor for Lebanese, to be honest, but it's extremely poor for the Palestinians. They're there in a centre which is map-supported as the Association Najda, you may know. It's not the state. It's not the Lebanese state. It's not another permanent, structured health provider. It's a local NGO supported by organisations like MAP. And so therefore it's subjected to the potential whims and strategic changes of donors. It's not national, although we try to make it so. The fact that the psychologist is Lebanese, it's great, she's great. But as you may know, Palestinians are not allowed to work as psychologists in Lebanon. There's 22 professions, health professions, which Palestinians cannot work in Lebanon. It's barred. That's among 39 professions in law where Palestinians are not being allowed to work in. And they've been there 70 years, obviously. Where that goes is that you've got your mental health issues are just one of a number of health areas which are of higher concern for the Palestinian refugee population and inadequately provided for. And of course, as it tends to be with Palestinians, very sadly, that they are marginalized, they are discriminated against in all sorts of ways, and at least half of them live in 12 refugee camps, which have not changed their size over 70 years. So there's lots of dense housing, often damp, leading to respiratory illnesses. You've got higher prevalence of communicable illnesses. You've also got high prevalence of NCDs, which are twice as high amongst refugee community as they are amongst the host community. And then when of course people get ill, so first of all they've probably gone to one of the UNRWA primary health clinics, where average time for consultation is 2 minutes and 45 seconds. Now in the UK, we love and complain about our health service. We average 10, right, Richard? And we complain about that, it's not enough. 2 minutes 45 for a Palestinian UNRWA, although there's all sorts of ways which are trying to improve it and make it even better. People get beyond that, they'll go to, often it's the PRCS, the Palestinian Red Crescent Societies. You've got lots of particularly hardworking nurses, a number of hardworking and skilled doctors and other medical professionals, but it's severely under-resourced. When we went to the Haifa hospital in Borj-Barajna camp, the youngest doctor working there was 45 years old. The head of the hospital told us that there hadn't been a single new doctor working in that main hospital for 15 years. It used to be, amongst the different ways where Palestinians would be able to access or to study properly to be a doctor, would be by going to Soviet bloc countries. And that, for good or for bad, ended as the bloc collapsed. Now they don't really have a place to study, they can't do it in Lebanon. There are still those who can study, and have studied, and they are working. They work and if they're working in the Lebanese hospital, if they're working in the Palestinian hospitals, they're poorly paid. So if they're in the Lebanese hospitals, they're very probably doing it in the kind of grey market sense. They're often working under a different name. They may well be disguising their accent, so there's less problems arising. They're not able to write prescriptions, so they need to have someone else. They will be paid less than the Lebanese, obviously. They may not have a contract. And imagine that for people who are better trained, perhaps better educated, and so on. The bulk of the Palestinians of Lebanon are low down, sadly, in the unskilled and semi-skilled jobs. The average payment for a Palestinian worker is lower, considerably lower than the Lebanese minimum wage. And that's been the case for 3.5 decades. Maternal child health is another area which Matt works on in Lebanon, and it's under-resourced in the country. Very sadly, the rates for stillbirth, perinatal and maternal mortality is the highest in all the UNRWA fields, indicative of all sorts of things going wrong. What really needs to be happening, of course, is that those discriminatory practices are overcome, that where Switzerland, UK, international community work with the Lebanese authorities to ensure that those discriminatory laws and practices are removed. But there's a long way to go, and of course Lebanon has its quite unique history and social, ethnic balance, and so on. There's some way to go for that. So if you will, I encourage you, please read our report, and we hope that you will help make the case so that the girl who may be sitting in that Najda Center in Badawi, or one of the other camps, is able to play with this doctor's set, which is on page 12, and actually not be kind of alienated by it. I mean, it's one thing to play with that nice, colourful syringe and stethoscope, but if you know that you're not going to be able to actually do that, I think there's something nice about dreaming, and if people like to imagine they're going to be an astronaut or something. Can you imagine how hard that is as well? And that obviously the healthcare system in Lebanon and for everyone should be driven by the people themselves, by the Palestinians. It should be locally driven. It should be affordable, appropriate, comprehensive, and across the board. So that's what we're working for Lebanon. Can I jump into Gaza? I won't say so too much because Dr. Marwan and Dr. Khamis have said so much, Dr. Hind too, and Dr. I didn't really know you, Doctor, before Joe, said so much about issues facing healthcare there, which we have been trying to support as well. I'm just going to run through a few things we've been doing and seeing. So, as you probably clocked, I'm not a health professional. I'm a social scientist, kind of a bit like an imposter, like a Palestinian working in a Lebanese hospital who may need to hide in a cupboard when there's like a security check on it. I'm not quite sure. Can I say popliteal? How do you say the popliteal triangle? Yeah. So okay. So you've probably seen some kind of preliminary research yourselves, which is talking not only about the extremely high level of 13,000 injuries and so on, but the very high proportion of snipers, high velocity bullets, which have been aiming at the lower legs. There's at least provisional information indicating that this is targeted, and it aims for the back of the knee, the popliteal triangle it's often called. So it kind of smashes the knee capsule, it smashes the arteries, the ligaments, the muscles, all kind of pulled together. And as you were saying, you've then got very long-term, immediate complex surgery, likely to take many, many hours, and then a series of other operations over a number of years, likely to also include not only your initial external fixators, but then after 6 to 8 weeks, tailor spatial frames, moving on to perhaps years of rehabilitation. Now, I'm pleased to say that Matt has been involved in not only releasing some of this pre-positioned emergency medical supplies, such as those frames and fixators, a number of kind of medicines, surfactants, and so on. And as mentioned, we've had surgeons and others working in the hospital, in the limb reconstruction unit in Al Shifa, which is phenomenally impressive unit. I mean, I've seen it briefly. And how they can continue doing that under such huge strain, it just, I mean, really beggars belief. I'd like to close. I need to block my computer here. Talk amongst yourselves for 5 seconds. So it's called the head of programs is Sheffield, UK. Dr. Andy Ferguson. He's just left Gaza, and he's been through at least one major casualty event in the UK. He said any hospital in the UK would be utterly overwhelmed by such a massive influx of injuries as we have seen in Gaza. Amid dwindling supplies of medicines and equipment and Gaza's chronic electricity shortages, hospitals in Gaza were in crisis even before the protests began. It is testimony to the motivation and skills of medical teams in Gaza that, despite this, hospitals were able to keep receiving, triaging, referring, treating patients, both the newly wounded and the hospital's standard patient workload. An example of this, on that awful day, Monday 14th May, despite 12 theatres working flat out throughout the afternoon and evening, at 10 p.m. there were still 70 major orthopaedic cases waiting for surgery, most of those with gunshot wounds. By 8 a.m. the following morning, 14 of these were still waiting, many in agony due to the unavailability of sufficient pain medication, even basic supplies, gauze, syringes, surgical gowns, running out. Almost unbelievable how awful that is, and a real testament to people such as Dr. Wan and Dr. Khamis, who've managed to kind of keep that medical response going. And finally, just from the advocacy side of things, it's been mentioned that the attacks on healthcare workers. What's been happening this time since March the 30th, of course, is nothing new. People will know how frequently the occupying forces in its offensives, one way or the other, have targeted or indiscriminately hit clinics, hospitals, ambulances, and so on. If you have time to pick up our Health and Occupation report, we have a nice description here, an infographic of many of the health services which have been hit again and again and again. And every single time, this has been done with utter impunity. No one has ever been prosecuted for any of these attacks. There's never been any meaningful independent investigation into any of these incidents. Particularly this week when, as was mentioned, it was the second anniversary of Security Council Resolution 2286, which particularly condemned attacks on health services worldwide, noting that they're actually increasing and calling for all sorts of measures to take place so it doesn't happen again. We still see that not happening. The international community has failed to stand by 2286. That's partly why we see forces, Israeli and others, continuing to attack health services with impunity, and impunity breeds repetition. And there will be more pain and suffering. Sorry to end on a negative note, but hopefully this sharing of information, ideas, recommendations, and appreciation for the health workers in Gaza and elsewhere can help ensure that Palestinians have a health system which they deserve. I hope there's an end to the blockade as soon as possible, and that international law is adhered in all circumstances, including with respectful resolution of the right to return. Thank you.
Thank you, Neil, and thank you to all you and your colleagues in what they do. Dr. Stater.
Yes. So first of all, thank you very much for coming. We added the firstly 10 chairs, and now we add another 10 chairs, so it's fully packed. It's really good to see that. Because we organize this so that people can hear from Gaza, but also wonderful people on the table and a wonderful hint. We came together, we're supposed to come together, and then that while I was waiting at the airport, the lounge that she's waiting. She never came. So I took my flight, while leaving she has another flight. The reason when I met her here that I asked her why you didn't come on time. She said that she was shopping, duty free. But the reason was, it's very serious. The reason was, she has to buy cosmetics, she has to buy what you call all these women's and also men's things, simply because she can't get them out from Gaza. Correct? only for your luxury. No? Because she really cannot take anything. I think even a toothpaste are not allowed. Forget about the laptop. It's not allowed. Only forget about the iPad. It's only the mobile one, right? Mobile.
Only mobile.
Yeah. So that's, I think, the story we need to hear. When you see the news that in Gaza that every Friday that there's a march and very horrible things happens, and then last one, the 14th of May and Monday happened, and then nothing happened. It's so far quiet. Right? Last Friday was quiet, and then it's quiet, right? It's not the end of the story. Actually, this is just the beginning. Beginning of the suffering, long-term suffering. As Hind mentioned, that we are primary healthcare centers. We do not do emergency because we are not meant for emergency. But what we have is that the number of gunshot wounds came when I went there last week before coming here for the dressing change. But it's not a simple dressing change. I used to be a doctor. I'm not a surgeon, I'm still a doctor. But from my very limited medical knowledge, they are not supposed to come to health center to dressing even. Some of them are really open wound. And some of them have abdominal wound, and then it really needs hospitalization. But hospital cannot cope with it because they have to prepare for the next wave of patients. So that's the reason they're coming to our health centers. And what's UNRWA is wonderful is that we responded to the needs. But say like number of casualties coming to this, you said 3 to 5 every day. Average 5. You know, we receive 4 million visitors in UNRWA health centers. So 5 in each health center is number-wise nothing. That's what I thought. And again, that I was stupid. One casualty killed a huge time. I think this is what you mentioned, right? And some of them really needs a 1 person, 2 person work with a sterile environment. But our dressing room is a mixture of the baby with the, what you call it? Asthma, the inhalation, and some of them are just abdominal pain, some of them, so it's a totally mixed place. And then they have to do this. I think that's the reason that that's UNRWA is going to suffer a lot. And then that we have a rehabilitation center 11. I already saw 3 people with a gunshot who came and then trying to do rehabilitations. But if we have a 3,500 gunshots, like what mentioned, if they all come to, majority of them are refugees, so if they come to our health centers, for the ones, our quick calculation, if the 3,000 comes, it means that the 250,000 increase in the visitors, which is impossible. It's totally impossible. So that's the story we need to hear. But also that we need to remember that because you mentioned Gaza and you mentioned Lebanon, I have to go to the West Bank. Say in Japanese expression, that there's an expression that you squeeze your neck with a cotton. Is it understandable? That's exactly happening in the West Bank. Say like in Gaza, sorry to say, it's a very, squeeze the neck with iron. It's really clearly understandable. In West, it should not happen, of course. But in West Bank, it is squeezing the neck with a cotton. And then blockade or checkpoint, occupation, settlement, economies, movement, and everything. And then going to East Jerusalem for this sophisticated care. Say August Victoria Hospital, which is one of the best centers in East Jerusalem, which means that within the border in Israel. And then that hospital has 5 full-time staff to do only the permission from coming to West Bank to East Jerusalem. So that's a reality they are facing. So that's also, I would like to remember this. And the reason I'm referring to this is, we had a session in the Palestine decision. Congratulations, it was passed. And it's approved by the 90 months. Yeah, it's good. Okay, we can go. And some of the countries said no, including some of the countries belonging to this panel. Not mine. They say that it is politicized in the World Health Assembly. It's not it's a pure technical ones. But please give me a break. First of all, once a year, let us listen to what the Palestinians want to say, which is you quite often forgotten. But once a year, let's realize that, if you ask me what the health problem in Palestine, it's a politics. It's simply politics. If you have a wonderful health services, which is blocked for the blockade, if you have wonderful health services receiving thousands of injured in a very short period of time, in Seahouse, the 500 patients, what Dr. Mara mentioned, came only 4 to 5 hours. So it's impossible, as Niels mentioned. So that's very important for us to realize that the politics is the dire cause of the problem of the Palestinians' health. And particularly among the youngsters, thank you very much for the IFMSA, that who are interested in global health. We should never forget that the political side of the health. Because what people suffer in the world is more in the lack of good governance, lack of security, lack of dignity, and lack of peace. That's it. I spoke to several people who went to the march. And I asked them, why did you go? I just want to be honest. We all knew that if you come in close to the fence, what the other side might do. And they are always aggressive on this. I'm not saying that they are correct, it's totally wrong, but nevertheless. What they told me is, I went to look for the new life. I want to have a new life with the dignity and the recognition from the original land we belong to. This is what many people do. And please just remember this. We have many 20s and early 30s people here, right? How many times you told to your parents, I want dignity? How many times you told among your friends that I want dignity? But each single one of the youngsters who went to the march I met said, I want dignity. I said, there is something totally, utterly wrong. I said, that's what we have to remember. And that we are here together to show the solidarity of Palestinians, but to show the rightness for the cause of the global health. Yeah, thank you very much.
Sorry, could you put that on full screen for me, however clever you did before? Looks good. Oh, it's up there, that's fine. Okay. So like a couple of other people have mentioned, it's a challenge to present in this sequence when there's been such eloquence and such heartfelt, not just words, but lived lives in the experience of providing healthcare in such challenging situations. And I come with some trepidation to this as an academic. Richard mentioned I can trail my Deputy Chief Scientific Advisor for DFID identity, but that's not my identity today. My identity is as an academic who, before I took on that role, a seconded role, I was funded by DFID in the Wellcome Trust to do something which at times before I anticipated speaking to that, I felt a little trepidatious doing, almost like a botanical activity of observing how people managed in such difficult circumstances. And yet, Gerald, in the middle of his talk, reflecting on the experience of providing healthcare in a developing world setting and comparing it to what colleagues said, they still have somehow able to somehow continue that. And then later Neil said how this was done under such strain beggars belief. That's the scientific question that I am interested in. And I'm nervous about it because very much I want to focus on the shocks to the system. And I think we're right to talk about the experience of that shock. But I want to give a little bit of a framing to what we've also heard about, which is the resilience of it, the capacities of it, not just particularly of the UNRWA health system, but also Palestinians served by that UNRWA health system. And I don't know how you're going to balance the resilience with the shock. And certainly my script is not to say that the resilience somehow compensates for it and somehow belittles the shock and the horror of the shock of which we've spoken. And yet, fundamentally, if we're talking about dignity, I want, in my 5 or 10 minutes of slides, to give dignity to the Palestinian health workers that have been working under these conditions and have demonstrated things that I think are not only deeply committed, but also a potential lesson for us in terms of operating health services under situations of strain. So this is work completed very much with colleagues at UNRWA, funded, I know earlier on, and with colleagues at American University Beirut who send their best wishes. I should be set to go. I'm going to try and tell a fairly quick story, and the current work is not in Gaza.
Excuse me.
Hello.
Yeah. This is coming together. Yeah. If you don't have anything for us, can you allow me or Marwan to leave because we go and do our break?
Yeah. Actually, I'll tell you what then. Let's have a pause and give the chance to have some dialogue. Alistair, so that's fine. So let's get Marwan and Kamis back up on screen. Okay, so let's open up the discussion here so that people can perhaps ask questions or give comments. Yes, please. And if you could let me come and I'll give you the microphone. Hopefully, and if you can tell people where you're from.
Okay, my name is Rania Mati.
Just can you hear?
Yeah.
Great.
Okay, my name is Rania Mati. I'm Palestinian Swiss. I work as a lawyer, and I'm representing a Palestinian NGO based in Bethlehem. First of all, I'm so happy that I got to know about this panel. I'm not in the sector of health, and I'm so happy to so young in this room, really, because in the UN, when we organize panels, always they are over 60. So I believe that empowering this age, this is how we can change the world. But I will not go out of this. First of all, I don't know if people, they understand why the Gazans organize this March of Return. What's mean March of Return? Do you know that it's the only population in the world, the only refugees, since 70 years, they don't have the right to return. Other refugees everywhere, when they got other nationality, they have the right to return back to their countries. The only one exception is the Palestinians. And this is since 70 years. Okay, this is not the issue now, just to tell you that the Gazans, when they said to this doctor, we are looking for our dignity. Of course, they have to look for their dignity. And now this year, we will celebrate 70 years of the Universal Declaration of Human Rights. But none of these rights, the Palestinians included. My question here, first of all, I don't know if the doctors in Gaza or MAP or other organizations, they have any collaboration or relation with physicians from human rights. I remember we invited them once in Geneva and they really did great presentation. Second, really, I'm really happy I'm sorry to saw these doctors through the screen, but I'm happy, I will be more happy if once we could see them in Geneva and with the help of these respected organizations. Thank you very much.
Okay, thank you very much. Who else would like to speak? And particularly questions that you might want to ask to two doctors on the screen. Who's next? Yes, please.
Good morning, well, good afternoon. My name is Camille Tertier-Bernay. I'm a medical resident and I'm here on behalf of the International Federation of Medical Students Association. I had the great opportunity to do an internship with Dr. Sita like 2 years ago for a few months in Amman in Jordan. And what I think I remember the most, a lot of things actually, but what I think touched me the most was the resiliency of the people working for UNRWA and also for other organizations. in related like to the Palestinian health. So my question now is for the kind doctors in Gaza, but also for you. I don't remember your name, but Hub from the health center. From the health center. In regards to the health programs that UNRWA is already taking action on, how do you think the situation right now in Gaza will affect like those mental health programs, and how you will respond to the increased probability of needs on regards to the mental health programs? Thank you.
Okay, thank you very much. Let's take another couple of comments or questions. This is your big opportunity. Yes.
Thank you. My name is Joseph Shenkler. I represent the type International Coalition of Housing and Land Rights Network. Obviously, Speak up. I'm in the human rights field, but in a different dimension from the right to health. But in our field and in the development world in general, we keep hearing about resilience as an objective, as a way of operation. But we've also been using the example of Palestinians as inherently the emblematic, resilient people who don't need to be told by development experts what resilience means. But in this debate that we're having about resilience as a concept, we and our members and in many fields, including food security, refuse to use the word resilience unless it's also coupled with the concept of liability. People who are resilient, who spring back from shocks, do so without, as we noticed, complete immunity on the part of those who create the shocks, who create the need for resilience. And I especially want to just point this out, especially for obviously youth and students who are here and involved in this discourse, that resilience as it's in itself is simply not enough unless we also, in the same breath, speak about liability, accountability, and resistance.
Okay, thank you very much. Any other questions for our two doctors here? Yes, please.
Hi, I'm Danny Sheath. I'm from the University of Geneva. I'm a scientific writer. I was just wondering, from your experience, have you seen any change in the behavior of healthcare professionals since the catastrophic injuries that have occurred amongst healthcare professionals? Have you seen them less willing to go into the field or more scared to perform their duties?
Okay, thank you. Let me come back to Dr. Marwan and Dr. Alessi. I hope you got to hear those comments and questions. Dr. Marwan, would you like to offer any reflections? Are we on volume here?
Okay,
I will answer the
question. I will
answer about why
doctors can't perform if they don't have enough skill to perform all surgeries or not. I think in our situations, all right, we are expert enough to work in primary at primary injury to deal with the cases really, but we were overwhelmed with the huge number of injured people that arrived on Monday, 14th of May. This will be beyond our capability and our capacity to deal with the huge number of cases that arrived immediately to our. We needed at that time more than 10 expert vascular surgeons, I think, maybe in Shifa and other places which are deprived of vascular surgery, like in the middle zone, we have another hospital which they don't have any vascular surgeon. And in the south of Gaza, we have another 2 hospitals, just European Gaza, which equipped, they have just 2 vascular surgeons, and Nasser Hospital, they don't have the vascular access and vascular surgeons there. So we are in deficiency of this number, but we are trained now our residents to perform this kind of operation. These are the numbers that are very huge, bind our capability and the capacity of Ministry of Health and the Minister and the hospitals of Ministry of Health.
Okay, thank you. Thank you. I'll just reply to the few questions from our sister from Bethlehem and the other guy who spoke about resilience and these things. First, she asked why we don't see at least one of the two doctors here in Geneva to speak themselves. Of course, that's a wish, but it's to be accomplished. We need at least 6 permits to secure before going out of Gaza. And I myself was supposed to go out to receive international recognition from Oxford University twice, 2 years. I got 5 permits, but the last permit was not denied, but was delayed. And for this reason, I think it's the responsibility of the international community and your great figures attending that meeting, maybe to help us go out of Gaza one day and to take part in person in such important meeting. Another thing I want to shed light on, please, when I think you are all figures into international health and global health. And one issue which I was about to speak about before this shelling and killing started in Gaza was the role of palliative and paying care during disasters. So I think we need to focus on the need of other people who are not related to injuries by Israelis, who are cancer patients who are suffering from chronic diseases, patients who are suffering from severe arthritic disorders. They are in severe pain and they need special health attention and special medical care. But unfortunately, when they come to hospitals during such times of disasters, crisis, they're all turned back and they just, okay, we cannot just do anything for you now because we are under emergency. So I think part of the proper healthcare provision to our people is not to forget the people who are suffering due to non-Israeli related injuries like cancers and others. And the final thing is, yes, we need resilient people. We need resilient hospitals. We need to build resilient community. But we don't ever imagine that we can ever build a resilient human being without giving him the basic necessities to survive. If he cannot guarantee the food for his family, he cannot guarantee the money for his kids to go to their school, if he cannot guarantee, if the doctor who's working in the hospital has no salary, if the doctor who's teaching medical student has no salary, then you don't expect him to be as resilient as supposed to be. Despite all of these negative situation in Gaza, our people still defiant, still steadfasting, still working hard under unbelievable conditions. Thank you.
Yeah. Sorry, just to repeat, I wondered if I could just pick up one of the questions from our audience. The impact of what's been taking place during the last few weeks on your colleagues, other health workers, on the nurses, the occupational therapists, the physiotherapists, the doctors, all the surgeons, I mean, those who are managing the hospitals, desperately trying to deal with this, the overwhelming nature of this crisis. Just at a human level, what has this been like for you all?
For us.
Yes, for you.
Yes, we got exhausted really at the end of these Fridays and last Monday, but still we have to cope with it. Yeah, okay, we are the only people, the only surgeons who are really exhausted. We can say this is the vascular surgeon and the orthopedic surgeon. The other part of the surgeons and the other part of the health workers, all right, they have less job than the others, or still they are working hardly with the others, but the main job really during this these Fridays and Monday, it is regarding to the vascular surgeons. They are, yes, exhausted. They need help from other colleagues from outside Gaza, yes, and the orthopedic surgeon. But they are very committed to work with our people. They are okay. They are ready to work anytime, in spite of they are getting tired and exhausted.
Okay. As for my part, since I'm more into medical education of doctors and doing clinical training for doctors, but I do also some clinical work. I was called to see 2 cases who were injured during these actions at Chief Hospital. And those 2 cases, one of them got comminuted fractures in both limbs. The other had spinal cord injury. And he's supposed to be fixated using total hollow vest or cervical fixation to the trunk. But unfortunately, he was only put in a Philadelphia collar because hospitals don't have such gadgets. After I saw those 2 patients, I found more than 80 patients staying in the same department. They're all very hungry, very thirsty for somebody to provide support and to provide help. And I can understand the pressure other doctors are under attending to other acute surgeries. So I was going to see 2 patients, but I ended up seeing 23 patients for over 4 hours in that night. And that's the amount of stress. But when you feel you're doing this for your countrymen, for your other people who are brave to go and exhibit their desire and express our basic rights of return, it's a price that's worth the pay.
And we're very grateful to you. I'm sure that our audience is extremely grateful to you. Please, let's give Dr. Khamis and Dr.
Thank you very much. You're such a great honor to Palestinian. You're the people who make us survive here. Thank you very, very much.
Thank you very much. Everybody in the room really does thank you for giving your time at a very difficult moment. And we send you all of our good wishes and our admiration and our courage. Thank you. So let us, and of course you're welcome to stay, but we fully understand if there are other pressing needs. Let's return, Alistair. Thank you.
Not at all. Oops, just help. That discussion actually works very well, and obviously we need to go into general discussion, so I will be very brief. But what I want to do is actually to very much build on the question that Richard was asking there, which was of staff. How are you coping? What did you do? How have you managed? And it's interesting that the answers given there were not just about personal things, but they were also about how the service had been adapted, how they had managed that situation. I've just put on the floor, so I can be quick, some handouts, which if you go for my friends at the AUB, and if you want a hand of this, and in the middle of it, that's the distilled story of around 150 UNRWA health workers across Lebanon, Jordan, and Syria, basically in response to that question, and the question of the shock in this case being the influx of Syrian refugees or the movement of Syrian refugees within the country, and the challenges to service delivery and the challenges to response. But the story begins with Dr. Sater and others in terms of the Gaza war of 2014, as I was saying earlier. Essentially, we were just interested in how did the health team cope during that period, and we began to develop this way of speaking with, and not just clinical officers, and not just health managers, but with clerks, with community organisers in terms of links to the clinic, and to try to understand from them not only what the shocks have been, but what their intelligent response has been. And I completely take the point about resilience, not, as we'll see in a minute, just absorption, about a confident assertion of agency in that environment. And so these were some of the content. This was during the 50-day war in terms of the provision and some of the challenges there. And we began to work with UNRWA, looking at their data over those 50 days, day by day, on what the disease surveillance was indicating with the disease threats. And we can begin to see, this is particularly in terms of health shelters, the shelters that people were evacuated to in a short period of time, but basically seeing remarkably continued staff attendance, thing we've just flagged of staff continuing to go to work very frequently. Patient attendance we'll see in a minute, but basically being able to control potentially some acute spikes of disease outbreaks when people are being pulled together. And beginning to look at, over time, the bombardment, the link between the conflict, the freedom to move, the freedom of staff to attend, and the control of sickness. And we did this looking at their data, but principally by talking with people and beginning to hear the story of we couldn't do this because we couldn't get the transport for that, and we couldn't get the transport for that because this, but someone called us on a mobile phone that gave us a lift to this clinic here, and we began to learn the story of the system, not the individual health workers, but the way that the health system had coped, had changed protocols, had evolved a protocol within the space of 3 or 4 days when the large number of evacuations was far in excess of what was anticipated. So with that introductory work with Dr. Sater, UNRWA and ourselves were involved in a research proposal to look at how across the various fields of UNRWA, with the varying contexts in which UNRWA was working in terms of the Syria crisis, how the UNRWA health system had been impacted and how it had responded. Now, Jordan, Lebanon, and Syria, where we've looked and we've worked with their teams, and so we've spoken with about 150 staff and community volunteers across those contexts, are very different contexts. They're very different shocks that they've experienced from Jordan, with a relatively small number of Palestinian refugees registered in Syria coming into the Jordan system, but still an increased burden. Lebanon, that being much higher, and clearly within Syria, major internal disruption. And so in the middle of this, I'm not going to go because we're short of time, I will leave you to observe both the challenges that those teams reported, but importantly for us, how they felt they responded. Now there's just 3 messages from me now until I put the microphone down. So the first message is the way that story is told is a shared account, and it's the account of a system. Now, I don't expect you to be able to follow the detail of that, but essentially this is how we understood the story in Jordan. Because of the conflict, there were increased numbers fleeing, and that led to coordination challenges and increasing population. The population seeking care increases, there are barriers to access, and we begin to understand the linkages in that system and how does a resilient system just stand still and continue as it does? No, it makes adjustments and adaptations as it goes forward. That's the story for Jordan, with a relatively, the health reforms that were talked about earlier happening, the conflict and the influx relatively minor. I'm going to go through these very quickly. That's the story for Lebanon, more complex with more refugees coming, more things happening simultaneously, and that's the picture for Syria. Now, the fact is, UNRWA is managing in that complexity. I don't expect, and I don't understand the detail of that complexity in 5 minutes now, but that, if you're a field health manager, those are the variables that's affecting patients coming, the availability of staff, the availability of medications, the coordination with relevant authorities. That's your field of operations. And you are seeking to behave intelligently within that system. And there is a lot of interesting detail coming from that, but for our summary, the second point I want to make is that essentially it boils down to 3 sorts of strategies, which I think begins to open up resilience as a concept that's quite useful to us. And you see these are illustrated throughout that centerfold. And there is a sense that some resilience is this notion of absorption. And in a sense, that's what our colleagues in Gaza are saying. I thought I was going to see 3 clients, but I'm seeing 22. I've taken it on. It's that shift. I've done more, and I've taken it on. I've managed. And it's just building up and building up, but I can take more. I work longer shifts. I don't take time off. We absorb, we share vehicle transport to get to other areas. There's a sense to which this is a taking in of the challenges. But what we see in the illustrations that you see there, that increasingly, it's not just a question of absorption, but adaptation, of intelligent changing of structures and processes. And that's the way that we normally do drug supplies. We need to adjust that. We need to tweak this, we need to move that, we need to establish staffing models slightly differently. And I think documenting the intelligence, and this doesn't happen, frankly, just with Dr. Seta. This isn't his intelligence, it's the system's intelligence, and sometimes a clinical officer, and frankly, sometimes a clerk who is behaving adaptively. He's understanding that the procedures need to shift a little, what documentation is needed. And then critically, across the three fields we see, and transformation is a rather grandiose word, but things becoming better. Things not just being a tweak of the system, but the psychosocial work that was talked about earlier has been given a huge, it's been hugely put on the agenda. There's been a huge response in terms of understanding that need in a different way. Different ways of introducing and operating services. Transformative in terms of a model that won't go back to what it was before, at the end of the Syria crisis, but a new way of working, a new way of learning, particularly in terms of skill mix and collaboration of staff. That's the second point then. So the first point is the complexity of the system. The second is that these notions of absorption, adaptation and transformation leak into each other. But give us an idea of the intelligent, adaptive agency of health workers is a useful framing. And then finally, if you're interested, and you could just stop there, but we've got a model and we've got all UNRWA's data for the last 10 years. And we can begin to put that data into the model historically and say, okay, what about the registered population as it increased? How did that influence the number of people coming to health services? And as clinics were open, as remote clinics and distant clinics were being developed, how did that change? We can begin to historically tell the story, which means that we can begin to simulate over time as the registered PR population in Lebanon, for example, increased, what the access to healthcare, whether that matched it, and what adjustments allowed it to be a more effective delivery of healthcare. The final is 3B. We can go backwards and say that this model sort of predicts what happens. What we didn't anticipate when we visited Dr. Seta in January was that we have a model that tells us what happened, but you can project this forward. And you can say something we never anticipated, given all of this data and given this model, what would happen if UNRWA had a 10% cut in its funding or a 20% cut in its funding? What do we know that would do to staffing, to utilisation, to number of women receiving 4 antenatal visits? And on the basis of this data, we can say what we think across all fields is at least 200 more women dying around childbirth and maternal mortality rate of an extra 200 women across the fields, and up to 2,000 more neonatal deaths per year across the fields with those budget cuts. Now, I talked to Dr. Seta today. Budget cuts isn't as big an issue as the Gaza blockade and the circumstances there, but we're working with a system under recurrent, continued threats and challenges, and we're trying to understand how they have managed that, but we don't presume their resilience to be infinite, and we can also use this work to signal what will happen in terms of population health, in terms of utilisation, if there are further curves to its coverage. Thank you.
Thank you, Hans. That's all.
I want to start with simple questions, and I want to ask, how do you feel if you got a crampy abdominal pain after you have eaten somewhere outside? Hopefully not today. How would you feel if your little daughter, or as so many young people are here, your little sister, got a fever throughout the night and woke up crying for that? How do you feel if you got a call that your brother had an accident and needs an emergent surgery? Well, of course you will be alarmed and scared because these are simple emotions and feelings that any human being would have if they are scared about their health or the health of their beloved ones. But how would you feel if you are protesting for something that you believe in and you got a shot, and then you were lucky enough to be rescued to a hospital, but then you are lying there in pain and bleeding, and all the people around you are maybe not only suffering a similar condition, but maybe suffering from a worse condition, and maybe crying for the lives of their beloved ones? How would you feel if your little sister or your daughter, who it might be okay that she gets a fever in this young age, but died from inhalation of tear gas? How would you feel if you faced these conditions? We are here in the World Health Assembly, and we go and attend all of these sessions with the theme of universal health coverage. But the question is, where does universal health coverage stand with all these marginalized and people who are affected in war zones? It is very difficult to neglect the existence and the needs of these populations, and it is very important to remind ourselves that we need to speak up and to stand for those people. Yet, most of these discussions that happens all around us in the World Health Assembly unfortunately fails to mention those people. And a lot of these discussions does not impose any focus on them. It's been 70 years for the catastrophe, or as we call it, Nakba. 70 years for Palestinian people who fled their homes, lost their homes, and were expelled from their countries without a right to return. It's been 70 years that those people do not enjoy any simple human right, not only in health, education, but also in safety and the freedom of movement. The political situation in Palestine is not only allowing having a very basic health infrastructure, but is also not allowing them to deal with the increasing morbidities, mortalities, and the lack of resources and the lack of health workforce. And all through the past days as well, we heard about the Al-Ma'ata Declaration and 40 years of commitments towards primary health care. And the other question is, where does it stand with marginalized groups and people under war zones? If we are going to have another 40 years of commitment towards primary health care, what are we going to do with that? What kind of primary healthcare system would sustain the continuous attacks, the lack of resources, the lack of health workforce, and increasing not only hundreds, but tens of thousands of injuries and people who need healthcare in each single day? And as we also keep hearing, there's no health without the health workforce, and it's only logical to equip yourself with a good health workforce to sustain such situations. The question is also, where is the Palestinian health workforce in all of this, in all of what is happening? In the International Federation of Medical Students Associations, we, the medical students, developed a report about the attacks on medical education in many countries in war zones around the world. In some of these countries like Libya, Yemen, Venezuela, and also Palestine. And when it comes to the medical education system in Palestine, and it's a new one, it was established in 1994, and then 3 other faculties joined, and with a total of 4 medical faculties in Palestine. This medical education system is having a very special case because it has to deal with the very unique and very special circumstances that this country and population is going through. And it has a very unique status as well because the health system is fragmented between private system, between the government, and between NGOs as well. Violence against higher education system is not a new thing. In this field, and is not a new thing to Palestinian medical students. In a report which was shared with, by UNESCO in 2014, and in the conflict period which started between the 7th of July and the 26th of August in 2014, they found that there was attacks against medical higher education facilities, including medical faculties, with no reasons to these attacks, which resulted in having not only staff and students being injured, but also in addition to the loss of equipments and facilities, which would impose a lot of challenges for any medical education system all around any areas that face such similar things. And in the Islamic University of Gaza, which started its operations in 2006, they also faced 6 airstrikes between December 2008 and January 2009. And out of these 6 strikes, there were medical faculties and medical and higher educational buildings and facilities that were targeted. And in the report that the United Nations finding mission on Gaza conflict, which examined the situation, they shared that they found no information which justified the attack on these faculties and buildings, or any information to their relationship to any military facilities or military groups. So can you imagine, along with all of these attacks, which happens every single few years, when there is an escalating in the violence situation there, how can a medical education system or a health system sustain all of this? And yet they are trying and they are doing much. In the International Federation of Medical Students Associations, we are committed to inform the future healthcare providers and the future doctors of the importance of this issue, that they should not never forget about the people in marginalized groups, and they should always take an active role in that. And we're very thankful for our relationship with UNRWA and for the chance for our medical students to have internship there and to get a closer look on the situation. And in the end, it is very important that we should remind ourselves that while we are speaking here and we are attending all the sessions of the World Hellth Assembly and the side events, some of those people who are under isolation, they are also under attack right now, and they cannot speak up and they cannot voice their opinions. And we should not neglect the situation from all the international agendas and discussions that are happening. And we should always voice our opinions regarding those people, because we might be their only voice in this. Thank you.
Thank you so much. We have a little bit of time for some reflections from you. And I know we've kept you quite late in the evening, and some of you have been running to the back to grab some sandwiches back there, I'm not quite sure, some food anyway. Who would like to make a reflection or a comment on what we've heard this evening so far? Any thoughts come to mind, particularly about what we might do given this situation? Yes, please.
John Zaracostas, I'm a reporter based at the Palais. My question is to the WHO rep in the OPT. If I recall rightly, and my memory is failing a bit, in 2008-2009, there was a lot of a rapid response from UN agencies on the amputees. I recall at the time UNICEF and HII were very active. What's the situation right now? Because I've been trying to get the numbers on the number of amputees, and I'm not getting these numbers, and what is the response from the specialized agencies and the UN?
Let's deal with that directly.
Yeah, well, I mean, the number of amputees, I can give you a fairly accurate figure. I mean, so far, I think we have 27 lower limbs amputations, a few upper limb amputations, a few femur amputations. But I think there are more to come, because many of them had vascular surgery and never know what kind of complications they might have. Also, some of the, obviously, complex fractures might eventually face further complications, infections, and so forth, which might eventually translate into amputations. The big gap at the moment is actually post-operative care and rehabilitation. MSF has drastically scaled up their capacities. A number of local NGOs are doing that, but they are by far not really covering the needs at the moment. So we really need to look into mobilizing more resources to address the post-operative care. One of the strategies is to bring in foreign medical teams to, first of all, strengthen the surgical capacity on the ground. But I mean, some of those patients will require 12 24 months of follow-up and rehabilitation. We're facing also some problems at the moment. I mean, Turkey has, for instance, offered just recently to transfer a number of patients to Turkey, but over the deterioration of the diplomatic relationship between Turkey and Israel, eventually they didn't find a way. They have evacuated, by the way, quite a number of patients during the 2004 Gaza war, but it didn't work out this time. But we're looking into ways to address this, but we are by far not prepared to meet the challenge.
Okay, thank you very much. Any other questions? Yes, please, at the back.
Hi, my name is Tina. I'm a medical school student from Los Angeles. So obviously, this is a very complicated issue, and hearing of egregious acts happening, and then the complexities from the politics and the health and the human rights, is there something that gives you hope for the future in the next 10 years, and as this situation unfolds, maybe a light at the end of the tunnel?
Wow, okay. That's a great question. Really great. Okay, let's open it up to everybody. On our panel, what gives you hope? Yeah, go on.
No. This panel is the hope. But those she is Palestinian. Enjoy. You see the hope for the Palestine here. Right? Right? Wonderfully. And then the famous duty-free shopper promised everything. That's the first. As far as we have a hidden battle, not by chance a female, as far as we have them, we have a future. That we have to help and continue to work. I think these two persons are global elite. I think what is important that we nurture and develop global people who can work in the global level to tell to the world, but to bring the change to the Palestinians' need. So there's a great hope. And the hope, sorry, this time, if you see this is one point of Palestine design. This is what we are doing together with not only the else, but also this one. I cannot sell to this. This is the first product, so that we have. If we start selling this, we can sell it. Okay?
I'm going to give you. We haven't got much time, but I'm going to give you an answer too. Every year we hold a meeting of what we call the Lancet Palestinian Health Alliance, and we rotate it around different countries in the region. And this inspires me every year. It's a 2-day meeting of young Palestinians across the occupied territory, Palestinians who are refugees in other countries, coming together to present their research, actually. And what they're doing is they're telling their story. The story of their people, the story of their nation, the story of their hopes for the future through the lens of health, through a beautiful lens of health. The majority of people who come, and we have hundreds, it gets bigger and bigger every year. This year in Beirut, the majority of the people who are presenting are the average age of people in this room, the next generation. That gives me hope, because this generation is inspiring, it's ambitious, it's committed, it's passionate, it's visionary, and they are dedicating their lives to their future, their family's future, and their nationhood. And I tell you, you go there every year and you see that, and you come away feeling like full of hope, despite everything that we've heard about this evening. So come next year, come next year to our meeting of the LPHA. Where are we having it next year? Is it Amman next year? Have we decided yet? Just come. In March next year, you're welcome. Okay, we'll have one more question.
Hello, I'm Jeremy from the International Federation of Medical Student Association. I have a question about the report that was accepted today. What is the impact of accepting this report on your work? Like, be it UNRWA or local or associations, what's the positive value of accepting that kind of report? Thank you.
Thank you. Okay, who's going to answer that?
Can I probably, I realise we didn't get much of a response to Nadia, who asked if anyone worked with Physicians for Human Rights some time back. So let me jump in there. I'll stand up too. As you may know, so yeah, PHRI, Physicians for Human Rights Israel, does go in regularly to Gaza. I mean, it has the name, it's based in Tel Aviv, Haifa area. Many people live in Jerusalem. Majority, or at least half of their staff, are like Palestinian citizens of Israel, as you know. We at MAP, for example, we have parliamentary delegations which go to the West Bank. If they could go into Gaza as well, we'd love that, but currently that's not allowed by Israel, and our Foreign Office discourages it. But we're seriously working on that with MPs too. But we meet with PHRI, we meet with them, the medical professionals, help hear the stories, and we worked a lot on the permit issue, which many people talked about. You recall just a couple of months ago, we worked really, really hard on this. We had a joint press release, which was MAP, Human Rights Watch, Amnesty International, Physicians for Human Rights Israel, and Al-Mazan Center for Human Rights in Gaza. And Al-Mazan mostly, and a bit of ourselves, we went through many of the cases, I hate the word cases, you know, the individuals who had been unable to get the travel permit to get to the referral in East Jerusalem and elsewhere. And we had 20 individuals who had died after being denied or delayed such a permit. Then, I mean, very soon afterwards, WHO had even higher figures of like 54. Some of those have been publicised. That information, I understand, is coming over coming months. There'll be more on that. But if you can find that press release, you will see that there's a link to 20 of the individuals, including Ahmed Shabir, with a congenital heart condition, who died, and he was in his early teens. There was Abir Abu Jayab, who had cancer, and she went to a MAP-supported health centre in Burej, and so on. So yes, we do work with them. They do good work, and some of their doctors have gone in and helped support with this. Yeah.
Do we want to make a quick final comment?
I think there was a specific question on the World Health Assembly report and what it means. I mean, it's difficult to tell. You saw the reaction of member states. Many of them have reservations that this is a politicized agenda. I mean, what we are trying to do is to keep it as technical as possible. It always then gets politicized in a way, obviously. Now, what's the value for our work? It gives us support from the organization, from the member states who obviously support our work that we're trying to do there. Other than that, it's an annual agenda item that many member states are not really happy with. And I think what they want to work towards is to get a consensus at one stage on the resolution. We were very close last year. There are always some stumbling blocks then that obviously couldn't overcome so far, but we want to keep it as technical as possible.
I'm going to draw this evening to an end because it's almost 9 o'clock, and I know other people have got meetings to go to. So I'm going to finish. We will have a chance to have a drink and talk at the end for those who wish to stay. I want to end with two final thoughts. The first is, it's very easy in a situation like this to have this kind of violence and oppression normalized in our minds, to think that this is the situation as it always has been, as it is today, and as it will be in the future, and therefore not to be as shocked and horrified as we should be when violence such as we've heard about this evening is unleashed on an utterly defenseless, oppressed population. Every violent act that we see perpetrated on the Palestinian people, we should be outraged and express our outrage in every possible way. And that can be something as small as writing a letter to a newspaper, sending out a tweet, trying to write an article for a magazine. It doesn't matter what it is. It is an act of resistance against that violence and oppression. And what we must never do is let this become normalized as a normal situation. It is a profoundly abnormal situation, and we must call it out. And finally, I want to make a comment on this issue of politicization, which maddens me completely. It was a political provocation to move the American embassy to Jerusalem. That was a political provocation. It was a political provocation, and it has been for 70 years, to systematically humiliate the Palestinian people. It is a political provocation to blame the people of Gaza for the events that we've heard described by Dr. Marwan and Dr. Alessi. So don't tell me not to politicize this issue when you have politicized the issue through your outrageous provocations that have led to these needless deaths and injuries. If we are going to address the health and well-being of Palestinians in the occupied Palestinian territory, our response must be to fuse medicine with humanity and with politics, with the objective of dignity, justice, and decency. And that should be our mantra, I think, as we end this evening. Health is political. Our goal is decency and dignity, and we need solidarity to that end. Please enjoy the evening. And thank our